Our panelists for this next session are Dr. Vidit Sharma. He's a urologic oncologist here at Mayo Clinic in Rochester, and Dr. Arnab Basu, a medical oncologist at Mayo Clinic in Florida. Again, their bios are in the book. We'll look forward to their talks.
Well, thank you for the invitation to speak. I'm always happy to talk about this topic. It's near and dear to our hearts as surgeons at Mayo Clinic. We have a long history of doing such cases. I'll just ask to advance to the next slide. Here are my disclosures. I think the only relevant ones are really me, Dr. Leibovich, and Dr. Khanna, and some of the other speakers have grants in kidney cancer from the AUA and Department of Defense. Next slide. So when we talk about locally advanced kidney cancer, I think it's a little bit of a different conversation compared to small renal tumors. Here, the tumor is bigger, which is why we call it locally advanced. And it is usually stage 3, meaning it has roots that extend outside the kidney, either into a vein that drains blood out of the kidney into another organ, or it is node positive, so it is already spread to the lymph nodes in the area, and so that would be N1. So locally advanced is defined as either a tumor stage of stage 3, 4, or N1. The most common kind, or one of the most common kinds of extension that renal cell carcinoma does is actually called a venous tumor thrombus, where that tumor grows into the vein that's coming out of the kidney. And those types of thrombi are subclassified. I'll ask to advance to the next slide so we can actually show you a picture of how this looks. So the kidney here is, on the right and left side, healthy kidney is the one without a tumor on it. And that big orange growth on the kidney is the tumor. And I use a lot of analogies when I talk about cancer. And my favorite analogy is perhaps thinking about cancer as a beehive. So that tumor is a bunch of cancer cells that are growing and expanding over time like a beehive. The more aggressive that hive is, the more likely it is to send microscopic colonies of cancer somewhere else that can be hibernating and invisible on imaging. But the more aggressive that hive is, it can also grow into other organs, and that's what we're seeing here. You can see that little tongue of tumor growing into the veins, and so the renal vein connects to the inferior vena cava, which then connects to the heart. And so these tumors can get relatively challenging to deal with surgically, and basically this is a very common presentation of locally advanced kidney tumors that we see as kidney surgeons. So this is a scenario where I think having real surgical expertise is very important, and I'll get into why later. But it's also a scenario where we are very vigilant about following patients up. And if we go to the next slide, we actually published a paper looking at a comparison of many different risk stratifications for these patients. And the AUA has a risk stratification called high risk and very high risk. And these locally advanced tumors fall under this risk stratification. So if we go to the next slide, I'll explain a little bit of data here. But basically, these lines represent the chances of cancer coming back over time. So the higher the line is, the lower the chance of cancer coming back. And if you look at the lines that say HR and VHR, so high risk and very high risk, the chances of cancer coming back for locally advanced tumors can be about 50% to as high as 80%. So this is a scenario where we are very vigilant after surgery to follow these patients, make sure we get regular CT scans, and try to find those metastatic colonies that are hibernating very early. And so that's one big component of the surgery is the follow-up. And if we go to the next slide, the surgery itself is more challenging often than regular tumors when they're much smaller. So here we're not talking about a partial nephrectomy. Usually we're talking about the whole kidney removal. And so the whole kidney removal itself is in many cases not as challenging when it's not locally advanced. But when it is locally advanced and you need to deal with vascular structures, liver, other organs, sometimes cardiac structures, I think it's very important to have a very experienced team. So this is the advice I give my fellows and residents when they want to go and try to learn these cases. The first thing is really do not be a hero, build a heroic team. So it's important to select a good surgical team that has a lot of experience with these cases, have an experienced anesthesiologist. If there's IVC involvement, make sure they're, uh, really well experienced with high blood transfusions, good access, central lines, and then have a vascular surgeon and a liver surgeon who have worked frequently with the urologist to come up with a surgical plan. And this is especially important in difficult cases. And then we always use an experienced cardiac surgeon when the tumor extends all the way into the heart. And I'll get into a little bit why later. But if we go to the next slide, we've actually looked at the data for how surgical volume experiences or influences complications, looking at our national data sets. And we studied about 112,000 uh, radical nephrectomies, so complete nephrectomies. And of those, 3.3% had IVC involvement and 0.3% had cardiac involvement. So these locally advanced cases are not the bread and butter type of cases just based on the percentages alone. If we go to the next slide, we can see the bar graphs of complications. So the blue bar represents the complication rate nationally when the tumor has invaded into the heart. The orange bar represents the complication rate when the tumor has invaded into the IVC. And as you could see, orange and blue bars are much higher than the gray bar. And so this is a situation where 10% of patients nationally can die if they have cardiac involvement within the hospitalization. And if we go to the next slide, we actually then related these complication rates to the volume of the center. And there was a clear relationship of the complication rate reducing as the volume of the center went up. And so having a center that does at least 20 such cases a year was a good barometer of having a lower complication rate. So I think that's a very important part of these surgeries. So if we go to the next slide, we can, I'm going to show some surgical images, and I think these images will help appreciate why these complication rates are higher for such cases. But patients often ask me, how did the tumor look? What did you see? And so this is some examples, but if we go to the next slide, this is an example of an open surgical approach, and you see a large tumor on the top part of the image. You see a blue vena cava that is going from left to right on the screen. And really, this tumor is about a size of a football in the abdomen, and it is displacing numerous structures. It is actually covered in fat, and some of that is also normal kidney in there. But we, as surgeons, try not to get too close to the tumor because we don't want to, violate the tumor. And so this is what we see. And if we go to the next slide, there's an example of the vena cava being cut open. There's no blood in the vena cava because we've controlled all the inflow to it. And there's a tumor with a small tongue invading into the vena cava. And it looks like a yellow tumor that has roots that are growing into it. And if we go to the next slide, this is an example of a bigger growth into the vena cava that multiple hands are delicately taking out of the vena cava and making sure that there's not too much blood loss and a safe margin around this tumor. And if we go to the next slide, when we repair the vena cava, we often put patches on. So here's some examples of patches on the right side of the vena cava. And basically, they're sewed on to make sure that the caliber of the vena cava doesn't change. And one of the reasons why you can see these blood vessels so clearly is because we've taken off the lymph nodes, which look yellow, covered in fat. And so that is often a part of this surgery. But if there was tumor in the lymph nodes, we would take them off to clear the vessels just like this. And so a patch reconstruction is often needed for these kinds of cases of the vena cava. If we go next, sometimes when the tumor is invading completely through the vena cava circumferentially, we can't just put a patch on it. We have to actually replace the whole thing. This is not as common as patch, but this is called a tube graft, where we just replace the whole thing with a plastic tube and we plug the other kidney in. I think in experienced hands, we can really do a lot with these locally advanced tumors and give good outcomes. And then one more slide next, please. In this scenario, we've opened up the abdomen and the heart, and you can see the heart at the top of the screen, and basically have access to the whole thing to take out the tumor. And this is multiple surgeons are involved for this case. One more slide next, please. So then this is how the tumor actually looks. This is a kidney cut open, and you can see normal kidney at the bottom looks purple, and then the tumor's kidney looks yellow and angry and nodular, and that tumor has a tongue that goes all the way up beyond the kidney. And those other little satellite nodules are how cancer behaves. It sends colonies to other parts of the body, including the kidney. So let's go to the next slide. Going back to our locally advanced outcomes, and one more slide, please. It's important to keep in mind that, again, these cancers, these colonies can hibernate in other places of the body for a long time. And so next slide, the question is, can we do something with medications to delay or eliminate the emergence of these metastatic colonies? And I think Dr. Basu will be talking about this a little bit in his talk. And just the little precursor to that is in our data set at Mayo, if we go to the next slide, we track our metastatic patients or patients who develop metastatic disease for a long time. And we've actually seen a patient in which metastatic colonies have hibernated for 37 years. So that's our record in our registry. But the key here is that a lot of patients will recur in this setting within the first 5 to 10 years. And those are the recurrences that are perhaps the most important to avoid or delay. So next slide. The way to delay that is with a treatment called adjuvant therapy after surgery. And there's many different criteria on how adjuvant therapies are evaluated, but we are still searching for the ideal adjuvant therapy. And this adjuvant therapy would basically delay metastasis, improve quality of life, improve survival, and have a low risk of side effects with low cost and a low treatment burden. So overall, I think there are some therapies that meet some of these criteria, but not all of these criteria. So it's an active area of research and further development. Thank you very much.
Great. Wow, that was a great talk from Dr. Sharma. Really a masterclass in surgical management of locally advanced RCC. I think I'm next. My name is Arnav Basu. I'm a senior associate consultant at the Mayo Clinic, Jacksonville. Before I begin, I would like to thank the organizers for this invitation. Great to see my colleagues and also to see our patients who we really do this for. Excited to talk about localized kidney cancer today, and particularly focusing on adjuvant treatment. So, how can we kind of collaborate with our surgeon colleagues who've kind of got the disease out? How can we reduce the risk of it coming back? And we'll see why that is important. Next slide, please. So these are my disclosures, some relevant ones. I do work in biomarkers, so I work with some companies that work on that as well. Next slide, please. So localized kidney cancer is actually the most common presentation for renal cell carcinoma. Unfortunately, the incidence is increasing in the past few decades, with an estimated 81,000 cases in the US in 2025. Fortunately, the outcomes in localized disease tend to be excellent, with a 5-year survival exceeding 90%. These numbers, however, fall very rapidly with increasing stage. And for this reason, patients who have localized disease and are at an elevated risk of developing metastatic disease have to be managed very carefully. So, how do we figure out who's at elevated risk of recurrence? Next slide, please. One of the most commonly used systems across disease types is the TNM staging system, which incorporates features of tumor size and reach So that stands for T. N stands for involvement of nearby lymph nodes, and M stands for any distant disease involvement. However, just using T and M misses potentially important risk factors like patient comorbidities, tumor grade, and other surgical characteristics like tumor thermos that Dr. Sharma so beautifully showed us. Next slide, please. So others have tried to incorporate several risk factors and develop better systems. It's great to have Dr. Leibovitz here, who devised one of the most utilized systems, comprehensive systems. There are simpler systems as well that I kind of just put here to show that we can do a little bit better than just TNM. And we'll talk about some of the modern developments as well down the line. Next slide, please. So the goal of developing these systems is particularly important for considering therapy called adjuvant therapy, which is treatment after surgery despite the lack of visible disease. The reason is we think that there might be some potentially micrometastatic disease in patients who have some of these high risk features and intervene on that before the cancer can become metastatic. So, as you saw, the survival goes down rapidly with increasing stage. So, there has been a lot of interest in adjuvant therapy for RCC, which is at an elevated risk of recurrence. And I have summarized here some of the larger randomized studies. Um, until about a decade ago, almost all therapy for RCC was directed towards VEGF or vascular endothelial growth factor receptor. These are pills that essentially reduce blood supply to cancer and are effective in the treatment of metastatic disease. Unfortunately, in the localized high risk setting, no trial was able to show any survival benefit, which means that it did not help our patients live any longer. You will see here that the S-TRAC study was the only somewhat positive study, but all it really did was to delay the time to appearance of metastatic disease without really curing any patients. Also, this was accompanied by the typical symptoms of VEGF-directed therapy, such as diarrhea, severe fatigue, hand-foot syndrome, elevated blood pressure, and other things. So, for this reason, sunitinib, the only positive pill here, is not routinely used in practice for the adjuvant therapy of renal cell carcinoma. Next slide, please. However, what we described so far was from the era of VEGF pills. We still use them. Use them in metastatic disease, but we have newer agents now, and those are the immunotherapies. So, immunotherapies are treatments that boost your body's own immune system to go fight the cancer. And one of the key drugs, immunotherapy drugs used in oncology today, is pembrolizumab. I want to go into more detail of a study of pembrolizumab that has changed the landscape of adjuvant therapy for RCC. So, this is the design of the Keynote 564 study, which was an international randomized double-blind placebo-controlled trial of pembrolizumab in patients with resected clear cell RCC at an elevated risk of recurrence. I do want to emphasize that these are clear cell RCC patients, which are about 80% of the diagnosed RCC patients. There are no positive trials of adjuvant therapy at all right now in non-clear cell RCC, an area of need, certainly. So these patients, in addition to having a good performance status and being trial candidates, had several elevated risk factors based on the TNM system, particularly um, PT3, such as renal sinus invasion, and other risk factors of PT4, node involvement. And also, we included patients who were metastatic at the time of surgery or around the time of surgery, but had one or two sites of those metastases um, resected or radiated to such a degree that the patient was clear of cancer after undergoing the procedure. So that is called M1NET. So these patients were randomized 1:1, almost 1,000 patients, and the primary endpoint was disease-free survival, so which is the cancer came back later at least, and the key secondary endpoint was overall survival, which really is the most important endpoint in an adjuvant study. Next slide, please. So these are the results of the study. Adjuvant pembrolizumab improved disease-free survival in the intent to treat population, with the disease-free survival at 24 months of 77.3% versus 68.1%. This is a hazard ratio of 0.68, which means that the disease-free survival was improved by 32%. This benefit persisted across almost all subcategories of patients, as a result of which pembrolizumab was approved for adjuvant therapy in high-risk resected clear cell RCC. Next slide, please. Recently, the survival data has been updated for this study and is now the first positive overall survival data in the adjuvant setting for RCC. Significant improvement in overall survival was observed with pembrolizumab as compared with placebo, with a hazard ratio of 0.62, which translates to a 38% reduction in the risk of death. At the 48-month mark, the survival difference was 91.2% versus 86%. Again, the benefit appeared to be across all subgroups. However, we must also notice that despite treating almost 1,000 patients with immunotherapy, the benefit is about 5% in overall survival at the 4-year mark. So, what is the toxicity cost of this intervention? Let's go to the next slide. What you see here is a tornado plot, which on the left is the severity and the frequency of different adverse events. You can see some fatigue, pruritus, which is itching, thyroid problems, diarrhea, skin rashes, and so on and so forth. The darker bars are grade 3, grade 4, which mean severe adverse events which sometimes lead to hospitalizations. You can see here that more or less the treatment is well tolerated without having major adverse events requiring hospitalization. On the right is kind of the time to when these side effects appear. And you can see here that they can be unpredictable. They can happen early or they can happen really late as well. Next slide, please. However, despite chemo 564 being positive, there has been a number of immunotherapy trials which have actually read out to be negative, suggesting that there might be smaller nuances to patient selection. The only positive or potentially positive IO trial other than Keynote 564 is the Rampart study, which was recently reported out, showing a signal of potentially double immunotherapy, but only so far on the disease-free survival, not on overall survival. Next slide, please. So, what we are seeing here is that immunotherapy can lead to lasting benefit, can cause true cures, which is the only thing that can cause an overall survival signal in such a large study after long follow-up. However, we are also seeing toxicities which are unpredictable and can be life-changing. And the question is, how can we balance this? Next slide, please. This brings us to a modern generation of risk stratification and the development of biomarkers. Biomarkers are circulating compounds that may potentially predict the residual um, micrometastatic or residual disease. And a very exciting one currently being investigated is KIM1, which is a transmembrane glycoprotein which is expressed in kidney cells, particularly if they get injured, and they are expressed in the same area of the cell where clear cell RCC comes from. There are studies that are showing that pre-nephrectomy levels of KIM1 can be elevated several years before an RCC diagnosis. There are studies that are also showing that KIM1 expression after the kidney has been taken out could be associated with a recurrence down the line. And also studies showing that while you are treating patients with advanced disease, KIM1 levels, as they move up and down, may actually be associated with an improved or worsened prognosis. Next slide, please. This is data from Emotion 010, which is one of the negative trials of the immunotherapies that we just talked about. However, when you look at KIM1 levels in this study, patients who had a KIM1 high had a much lower probability of survival and much lower probability of remaining progression free. In fact, in some of these studies, the highest levels benefited from immunotherapy. It appeared to be, even though the study was not geared or designed to answer that specific question, you know, in KIM1 positive patients. Next slide, please. Other than KIM1, there are also some other novel markers, one of which is called minimal residual disease or molecular residual disease, which is essentially a signature created from the original resected tumor, and mutations are selected out and found, and only the specific mutations in the original cancer are selected. And then these are greatly amplified using modern techniques in the plasma, and that can be done on a serial basis. So what you're seeing here is the very first, to my knowledge, the very first genome sequencing based ctDNA longitudinal monitoring data, which is really from a real world cohort, but over a relatively long period of follow up time. And there were about 30 patients that were followed for some time, and we saw that in these patients almost all the cases of recurrences were picked up by genome based MRD monitoring, and patients who remained negative were disease free. So this is providing a the background science for hopefully designing studies down the line that can potentially incorporate that into making adjuvant decisions. Next slide, please. So, key take home points. Some factors like venous sinus invasion, tumor thrombus, lymph node involvement at surgery can increase the risk of recurrence. Pembrolizumab therapy in such situations can improve survival and has grade 1 evidence. A small but meaningful risk of toxicity exists, and biomarkers are being developed to tailor therapy. Thank you very much for your attention, and I hope this is helpful. Happy to answer questions.